The earliest versions of endotracheal tubes had cuffs that were very low compliance and required very high inflation pressures in order to stretch the cuff material enough to contact the tracheal wall. Even later versions of high compliance cuffs, whose fully inflated resting volumes are smaller than the patient's trachea, must be stretched in this fashion. This may lead to cuff inflation pressures so high that blood flow to surrounding tissue could be cut off, which may result in damage to the trachea. Conventional high-volume, low-pressure cuffs are intentionally designed to have a resting diameter that is larger than the trachea. Thus, they contact the tracheal wall at low inflation pressures that do not impede blood flow to the surrounding tissues. However, since they are larger than the trachea, the extra cuff material can fold over on itself, creating folds and channels through which fluids can pass into the lower airways. This is called microaspiration. The ideal cuff would exactly match the diameter of the patient's trachea with no folds and channels and at appropriate inflation pressures. But how do you determine the precise size of an individual's trachea? And with the wider variability between endotracheal tubes, how do you select the appropriately sized tube?